So our next presentation will be given by Seeta Ramdass. She has a solid understanding of healthcare systems and working with university teaching hospitals, as well as the needs of patients and their families. Thanks to a career spanning more than 25 years in the healthcare public relations and communications field. Most recently, she was the director of the public relations and communications for St. Mary's Hospital Center, a spokesperson for the McGill University Health Center, and also held patient advocacy roles in the Montreal community. She encourages cultural sensitivity with respect to ethnicity, race, religion, language, disability, gender, sexual orientation, and socioeconomic factors by serving on the task forces for the McGill University Faculty of Medicine and for other local and international hospital and university networks. Ms. Ramdass is involved with many task forces in health and education organizations dedicated to sociocultural, safe and sensitive health care, including the Community Health Montreal, a patient-centric initiative that is working with marginalized communities to tailor the delivery of healthcare services to the needs of each community. Her presentation today is titled Misinterpretation, Misunderstanding, and Misdiagnosis. Again, if you have any questions, please ask them in the chat as we're going along, and we'll address these in the Q&A session. Seeta, I understand you have a colleague joining you. Would you mind introducing him before you begin?
Yes, absolutely. My colleague is Mr. Ronnie Santos, and Ronnie will be helping me by portraying the voice that is very rarely heard often in debriefs about patients. So he will be representing the patient's voice. Ronnie works with me with a new project called the National Newcomer Navigation Network, which is a Canadian project to develop a network for those from different organizations who help to navigate newcomers throughout the country of Canada, both with respect to healthcare and social services needs. We talk about navigating refugees, asylum seekers, people who have been displaced involuntarily from their countries of origin, and he will accompany me today in the reading. So, just to tell you a bit more about myself, I'm a patient advocate, as was mentioned, and co-chair of a patients committee, which is based at the McGill University Health Center. I'm also on the board of directors of an organization called the Council for the Protection of the Sick, and a member of the Family Advisory Forum of the Montreal Children's Hospital, which is a pediatric hospital, and I'm on the patients committee for over 20 years now. This hospital serves a very large, socioculturally diverse group of communities, from Indigenous peoples to refugees and asylum seekers, immigrants from other places. And my work in healthcare really revolves around establishing socioculturally safe health and social services, because there are so many barriers to getting the proper health care and social services in a cultural context. Language can be a barrier, customs, religious beliefs, income, age, gender identity, the list goes on. My presentation is based on excerpts from a clinical debrief on a patient who is of a very different cultural background from those that are in charge of his care. Among the excerpts, there are characters who act directly on the patient and his family, and there are other actors or influencers on the patient and on the patient's outcome, who are personified or portrayed through characters such as time, innovation, logic, and the healthcare system itself. Although these characters may be abstract, they have an impact on this patient, on his family, and in fact, on all patients in the community, and particularly in this context, as you will soon understand when we read a bit more about him. The patient is never in their own clinical debrief, nor is the patient's representative ever in their own clinical debrief. But in this case, the voice who knows the most about the patient culturally, the patient himself, you'll hear what he could have said that he didn't get a chance to say. You'll hear from a family member who understood him, whose voice really wasn't considered, and from the cultural broker, which is an emerging profession, sometimes called a cultural navigator, who is still not recognized among the clinical professions, but whose voice actually truly captures very important elements that are critical to providing this patient with the proper care. The patient himself, Kalim, is a 76-year-old male. He has a history of heart disease. He can walk maybe 2 or 3 steps, and then he's out of breath. He's very easily fatigued. He speaks very little English, and his dialogue is generally through a translator. Let me introduce you right now to Kalim.
Hello, I am a 76-year-old male patient named Kalim. I have a history of diabetes, heart disease, and hypertension. I immigrated here in my 20s, so I have lived here and contributed to society for 50 plus years. I come from a family of 10 children. We were poor, food was scarce, and medical care even more so. I am one of the first members of my community and the first member of my family to immigrate here from Andhra Pradesh. My mother tongue and customers are Telugu. When I got my first apartment here and found some steady employment, I was able to sponsor some family and friends. People from my village and area eventually moved here over several years. I put them up in my apartment until they could support themselves. They eventually rented in the same apartment building and sponsored some of their family and friends too. After just a few years, members of my community have moved in my building and other buildings next door. I eventually started a business here, a small grocery store that grew from selling local goods to foods and products for my culture as well. I was able to provide culturally familiar foods and products to my community and introduce new items to the locals. Everyone could shop in my store and find things of interest and need. I employed over 40 people full-time, which meant all these people had an income and were able to sustain their families and their communities. My employees came from different backgrounds, but most were from my own culture. With the help of my community and the generosity of my customers, I raised money to buy and renovate an old dilapidated building into a small temple for our community to worship, to gather together to celebrate, to mourn, and to heal. The temple was not just a place where we worship, it was really our community center, our school, and our clinic. I was no longer alone. My community was growing and evolving around me. I was at the center of my community. They counted on me to help them get settled, learn their way around, and adapt to the new country while still maintaining our cultural values. I did what I could to preserve my own heritage while adapting to the wonders and privileges of my new home and living in harmony with my new neighbors in my new country. The people of my community view me as an elder and founder of our community here. They look up to me and expect me to lead them, advise them, and care for them. They depend on me, and I cannot let them down. I must be strong for my community as an elder. I practice and teach the ways of our customs, using the healing herbs and rituals of my ancestors, conducting the prayers and the special religious life and death ceremonies of my heritage. As a leader in my community, I have many roles: father figure, advisor, teacher, and healer. I cannot be frail or weak or let my people down. I had a cardiac bypass procedure last year. I tried to hide this from my community, but they find out anyway since I was absent from my business, community events, and the temple. Since then, I have lost my wife suddenly and unexpectedly. She was a warm, caring person who helped me run my business from day one. She helped me to care for our community and preserve our traditions. Her sudden loss has been difficult for me to deal with and has been hard on our community. Now I am too old and sick to run my business, so I retired. I lose my balance often and I have joint pain, especially on my hips. I had hernia surgery a week ago. I was discharged from the hospital next day, despite the fact that I was feeling dizzy and in pain. They gave me pain medication and I sent me home. One day after being discharged, I fell in my house and split my head open. There was a lot of blood. I don't remember much after that. My younger daughter took me to the emergency room. They asked me if I had pain and I shook my head from side to side. They said, good. They asked me if I felt dizzy and I shook my head from side to side. They seemed pleased.
Hello, I am the cultural broker or cultural navigator. I just met this patient. He is of Telangana background. In this culture, shaking of the head from side to side means yes, not no, as in North American culture. He is from the Brahmin caste of his culture, which means that his people view him as a teacher, religious leader, and protector. Hello, I am Shanta, the daughter and caregiver of the patient. I need help to take care of my father, who is very frail. He has heart disease and diabetes. I have been trying to get this help since last year after he had heart surgery. I don't really know how to take care of him, and I am scared to lose him. I did not learn to take care of the sick. My mother died suddenly, so I never learned to take care of the sick. I need someone to check my father because he is getting old, and I do not know how to take care of him. Yet I have to take very good care of him because it is my duty as a daughter to him and a duty to my community, because he is an elder and a leader and of the Brahmin caste. I am the cultural broker. The daughter Shanta has been trying to get a geriatric assessment for her father. Because she is the only daughter in the family, she is responsible for her parents. And because of her father's prominent role in the community, she must devote herself to his needs. She only completed high school, and then she had no choice but to help her parents by working in her father's store. She has no personal health insurance coverage and is unaware of this need or her own personal needs, other than she must care for her father. She is rather isolated because she is devoted to doing everything for her father, caring for him and coordinating his schedule for his important role in the community. She is not used to asking for or receiving help, as she has fallen into the primary female nurturer role, especially since her mother died. Furthermore, in this particular culture, there is a general reluctance to ask anyone for help, especially for an elder who is a leader, for fear of appearing disrespectful to that leader, elder. Hello, I am Shanta again. I care for my dad full-time. It is exhausting work, and I am close to burning out, but there is no support for me. I have never told anyone before about how tired and stressed I am. I have no medical or nursing experience, but I have to push through and do what I can for him. I use our traditional spiritual and healing practices to help my dad, but this is not enough. His medications and cost of living is very expensive and impossible to be covered by his small pension and insurance. I am still waiting for someone to help us to get the materials he needs to navigate around the house, like getting in and out of the shower, using the bathroom, etc., because he has the tendency to fall. He needs a walker or a wheelchair because he cannot walk or stand for too long, but he does not want them. He had hernia surgery last week. He was discharged a day later, despite my concerns to the medical staff that he is on blood thinners and is weak and wobbly. When we got home, he said some very confusing things, as though my mother was still alive. He called out for her. He also had an episode where he sat very still and speechless for close to an hour. He fell in the house while trying to get up to go to the bathroom and split his head open. I called an ambulance and we went back to the hospital where he had his hernia surgery 2 days ago. He waited for 4 hours before having a CT scan. We were told that he had a brain bleed, but since he could speak and confirm his name and that he had no dizziness or pain, the doctors sent him home. I know my dad best, and I told the medical staff that some of his behaviors earlier were not normal and that he was confused. I called his family doctor and his cardiologist. They said that he should be kept and monitored at the hospital because he is on blood thinners. I told them that the emergency room staff discharged my dad and simply told me to call 911 if he got worse. As his caregiver, I was not allowed to be in the room when he was being examined and questioned by the hospital staff. I know he is dizzy and has pain, but somehow the doctors think otherwise and sent him home. I do not understand why. I am worried about what could happen to him at home, and I am not qualified to care for him. I don't know what to do if he gets worse. The cultural broker or navigator. Hi, I'm the cultural broker. A social and clinical assessment of the patient and his family environment is urgently needed. It would be helpful to have some home care arranged, as well as some financial assistance, especially since the daughter is the only full-time caregiver that the father and that the community trusts with his care. The Telugu nonverbal way of communicating the word yes is to shake the head from side to side. Kalim, when asked if he was in pain and dizzy by the medical staff, shook his head from side to side to confirm that he was, in fact, dizzy and in pain. However, this action was not interpreted in the context of his culture, but rather in the context of the clinician's culture, rendering it a gross misinterpretation of the actual response of the patient. The clinician thought that Kalim was not in pain and that he was not dizzy, when in fact he was. In this culture, it is very important for Kalim to show his community that he is still autonomous and strong, especially since he plays many roles. He's an elder, he is a leader, he is an advisor, and a healer. In his culture, it is inappropriate for any woman outside of the immediate family to care for him, and his community is not comfortable asking for help from those outside the community, especially for him, because in asking for help for him, they may appear to be disrespecting him, a very offensive thing to do to a Brahmin in this particular culture. Hi, I am Shanta again. My father does not want to have anyone else to take care of him but me. The community does not want anyone else to take care of him but me. He is not comfortable with strangers caring for him. He wants to show he is still able to take care of himself and the community that he is still strong. In our culture, it is inappropriate for any woman outside of our family to care for him. He does not want to get financial assistance because he must show that he is independent. All of this is necessary for his self-esteem and to fulfill his responsibility as an elder in our community. I would like to help maintain my father's dignity and preserve his status in the community. It is important to him, especially since my mother died. It is also very important to the entire community that he is kept close to them. As the only daughter in my family, it is my duty to support and care for my father. It is my honor and my privilege to care for my father. My personal desires and wants are not important in my culture, only fulfilling my duties to a highly respected community leader who happens to be my father. It would be very helpful if I could be trained to be a professional caregiver, so I do not have to ask for outside help to care for my father. I can do it all myself, which will make him happy, is better for his morale, and is expected of me by him and the community. I never had the chance to learn beyond high school, and I would like to learn to provide care to others in a professional way. Hi, I'm the cultural broker again. We have to help the patient with his disabilities, but we also have to help the caregiver. She needs support and training. Hi, I am the union. I have another perspective. If we start compensating and training home caregivers, then we will lose jobs in the healthcare network. Logic. Hello, I am Logic. We should have transition care units, rehabilitation units, step-down units, and more community-based long-term care places to help elderly patients get back their autonomy. These should be culturally safe and sensitive environments located within the patient's communities to keep them in familiar neighborhoods, surrounded by familiar community members who can play different caregiving roles and sustain this patient more efficiently. If we do this, then it may help prevent them from relapsing and ending up in the emergency department and occupying acute care beds with their long-term needs. It will be good for their morale, and the assistance and participation of the community in the care of the patient may also save the healthcare system some money. Good afternoon, I am the hospital administration. Our emergency department is bursting at the seams. Wait times exceed 15 hours. We have many elderly patients who need complex care. Our acute care beds are congested with many of these elderly patients because there are not enough beds in the community to take them. It is challenging to admit more complex acute care patients if we cannot liberate our beds of long-term care patients. Having socioculturally safe and adapted environments is important, but it's just not a priority right now. Acute care is. Good day, I am the Health and Social Services System. Creating culturally safe and sensitive transition care units, rehabilitation units, step-down units, and more community-based long-term care places for the elderly is a nice idea, but it is not a priority right now. That is a very resource-intensive and cost-prohibitive task. I will need human, material, and financial resources to inject into this task. This will take time. Hi, I am time. I have been observing this phenomenon for over 30 years. This is an old and worn out excuse that many previous bureaucracies have used. Over the past decades, I have seen numerous migrations of various cultural groups into our country. I have seen millions of patients and their families go through similar situations like this. It's the same old story. We have become a more socioculturally diverse society with hybridized cultures among us. This trend will only continue. Logic and innovation. Hello, we are logic and innovation. The government, bureaucrats, etc., are complaining about resources. Well, why not recycle some of the abandoned health institutions you already have? Some of them are already adapted for patients with physical and mental challenges. Why not use medical, nursing, and allied health care professionals in training to staff these facilities? Why not engage more cultural brokers or cultural navigators in the multidisciplinary teams who care for patients? It would save lives and improve the quality of life. Oh, and whilst we're at it, why not use technology such as digital games, videos, etc., to help treat and improve patients' autonomy and functionality? Hello, I am society. There are many more people in this country over the age of 55 than ever before. Data from the latest census showed for the first time that there were more people aged 55 to 64, typically the age group where people leave the labor force, than those aged 15 to 24, typically the age group where people enter the labor force. These older people contributed to building our great country. They served our communities. They want to continue to be active and involved as they age. Why are we not better prepared to help them have a healthy old age instead of just letting them age? We can enable them instead of sustaining their disability or inability. Good afternoon, everyone. I am the coroner. While all this has been going on, the patient and millions more like him have died. Miscommunication and misunderstanding played a role in his death. There is a need to implement socioculturally safe and sensitive measures to manage the socioculturally complex barriers to health care that exist in our very diverse society. We need support and action by those with the power to implement change and preserve the health, well-being, and dignity of all patients from all backgrounds. So thank you so much for allowing me to share this excerpt about this patient. Just a disclaimer, Rest assured that the name of the patient was changed to protect privacy, as was the name of the daughter, to respect the confidentiality of the family, although the scenario is real. What I wanted people to understand about this particular scenario is that something as simple as a cultural custom of how the words yes and no are expressed, nonverbal communication, played a huge role in the diagnosis, or I should say misdiagnosis, of this particular patient. The role of cultural brokers, cultural navigators, they go by so many different diverse names because this is a profession that, while it is very important, is still very unrecognized as part of the clinical team. Is so important because it was the cultural broker who was able to really confirm and clarify to the clinical staff that when a person from the Telugu culture shakes their head from side to side, they're not really saying no, they're actually saying yes. In the case of an elderly gentleman with very low verbal communication skills in English, the nonverbal cues were very important in expressing what he was going through. Another important element of this, the daughter who herself may only have had high school education, is an expert both in the patient, her father, and in his care with respect to the community. She herself is also an excellent cultural navigator. But during the evaluation with the clinicians in the ED, she was not allowed to be present when they asked the patient about what happened after he struck his head. Because she was not there, she could not explain that her father was actually confirming that he was in fact feeling dizzy, that he was in fact having headaches. She was also not included in discussions about his well-being because had she been included, they would have understood more about the fact that he was on blood thinners before he left the ED. And she would not have been put in a position where she had to try to phone and get the other doctors, the other specialists, to find out more information that may have helped her father. The daughter herself, Shanta, also is not empowered as his caregiver by either the clinicians or the system itself. And again, we see that it is the voice of the cultural broker who clarifies not only on behalf of the patient, but clarifies also on behalf of his primary caregiver, the daughter, to demonstrate the importance of her role and to explain that she is not simply someone who is there as a passive caregiver. She's actively involved on behalf of her father and on behalf of an entire community. Another important element of this particular debrief and the excerpts that were selected is to show that in the Telangana community, there is not individual decision-making that transpires, but rather collective and community decision-making. The daughter tries to convey that through her own language and through the words that she uses, that there is an importance of her father's role in the community and of her own role in supporting him for the community. She talks about what the community wants and her father recognizing what the community wants, and they are acting in a context that will be beneficial of the community while at the same time preserving her father's leadership role in the community. So this is another element that is a barrier to care that we often overlook, and that is individual decision-making versus collective decision-making. We also learn another important lesson through this particular dialogue, and that is that there may be a willingness in caregivers to do more, but if they themselves are not empowered and they don't have an interpreter or someone to act on their behalf, they recognize their own frailties with respect to helping a patient or providing home care. So the caregiver and the patient have a symbiotic relationship that should be looked at as a whole and not as two separate entities. They're definitely connected. Another lesson I think we learn here is that this excerpt again focused not on the pure clinical health needs of the patient, 76-year-old male patient with a history of heart disease, who's easily fatigued. No, this looked at the social and community elements of this patient so that you see the whole person. And I think that when you see the whole person, the language barrier, the nonverbal challenges in interpreting what he's trying to convey, you get a more comprehensive picture that allows both the clinicians and the social services providers to adapt the care more to his needs so that the patient has a better or potentially better outcome. I think that the other issue that is important is that overall, we look at a story that reflects a phenomenon that is going on certainly in North American societies and developing countries. We are all receiving our fair share of newcomers. These are people who may be voluntarily immigrants. These are people who may be forcibly displaced from their homelands through persecution, environmental disasters, but they're coming into our lands with no knowledge of our cultures, and we also have very little or no knowledge of theirs. Navigating through our complex healthcare systems will be very challenging for them, has been very challenging for them, and continues to be challenging unless we really focus on adapting care and social services to the sociocultural context of newcomers. I will pause there at this point, and I will be happy to take any questions or comments that you may have.
Seeta, thank you so much for this presentation, and to Ronnie for representing Kalim. I bet you haven't been able to see the Zoom webinar chat as you're presenting, but I wanted to share the method you have for sharing this presentation has received a lot of accolades. People are saying amazing, creative, brilliant method. So thank you for doing this today. At this time, I'd like to invite our reactors and for you, Seeta, to turn on your webcam. Great, thank you so much. We've had a few questions coming in from the chat, so I'll go ahead and start with these, and then we'll tune into the reactors about some of their thoughts about the presentation. So first, Elaine LaBerge commented, an amazing way to get all of the voices to the table. I will draw on this as a KT strategy with my own work that doesn't, for those who don't get a seat at the table. Do you have any advice for Elaine about how to go about doing that?
It's very challenging, but it starts with thinking beyond just the clinical teams that look after a patient. The receptionist who first greets the patient might be part of the discussion. The transport attendant, the clerk who registers them. In fact, where I currently am in the Children's Hospital of Eastern Ontario, we know that with the recent influx of Syrian refugees, for example, it was an emergency room clerk who was their primary navigator for people who did not speak a word of English and who came here traumatized, victims of horrors that we couldn't possibly understand. So looking beyond just the clinical team at all the points of encounter of the patient. It is very challenging, but it can be done. The best way to do it is to pretend that you are the patient, or to even get a more authentic version of getting a patient with limited language, common language skills, and maybe even a patient who is freshly arrived, if you know anyone who just came to the country or to your area, and have basically the trajectory followed. So you literally pretend you were that person or follow them as they come in. Look at the body language, look at how they're received from everyone, the security guard when they enter, if they enter by the emergency room, or if it's the receptionist in the clinic, the trajectory and every personal encounter of everyone working that has a hospital ID will help you, and bring them to the table. All these people have a voice at the table. We have learned from transport attendants amazing things about what goes on with patients from different cultures. Sometimes it's simple things like a woman from certain cultures feel uncomfortable being transported by a male attendant. And the male attendants have found ways, when they're only male attendants, of how to respect these women in their cultural context, but get the job done of transporting them from point A to B in the hospital, for example. So engage these non-clinicians in the discussion, bring them to the table.
That's so important. Another comment that came in was misdiagnosis is certainly seen with misinterpretation. So you mentioned the cultural difference between shaking the head versus nodding to indicate agreement. Are there other examples or very common gestures in one culture that you're aware of that can mean something different in another, or perhaps common behaviors that can be misinterpreted?
Absolutely. We can take a look at the Greek culture, for example. So I can briefly tell you the story of a young nurse who worked in an elder care center. Her job, she was assigned to an elderly Greek gentleman who refused to have any social interaction with the other staff members, the other patients. He would not go into the social room. He would not go to the movie room, nothing, not the exercise room. He didn't really want to talk to other staff at all. So this young nurse was assigned because she just had this wonderful sunshiny personality. And she would go into his room where the gentleman would stay pretty much the whole day. And he would just kind of give everyone a bit of a grumpy look and, you know, shoo them off. After about a week, during, again, this is the clinical staff gathered around the table, debriefing about the patient, she said, "I think I'm making progress with the patient, because now when I walk into the room, he gives me a little wave of his hand. And when I leave, he gives me a little wave of his hand." She believed, as did the rest of the clinical team, that the introduction of the acknowledgement of that little hand wave was a positive sign at the end of 1 week. In fact, in the Greek culture, the little wave of the hand, which I'm not doing quite accurately for a reason, that little wave of the hand is actually an insult in the Greek language. It's pretty much the flipping of the finger, I guess, is the best way to describe it. And so he was not receptive. He did not want her there. And the misinterpretation of that meant that people were barging into his room and trying to do more things with him, just agitating him even more. In fact, subsequent to that misinterpretation, people kept trying to go in his room and engage him and talk to him. There were more code whites called on him within the first 2 weeks of them doing that. I don't know if you know what code whites are, but you know, that's when a patient gets a little aggressive and agitated and has to be maybe restrained, because they were invading his privacy in large numbers, when what he was really trying to say was, "Please stay away from me." I can give you another example, one more, which I think you probably have, is a very common encounter. A gentleman from an African nation who was in our emergency room when I was at St. Mary's Hospital. This gentleman came in and he would not answer questions from the clinicians. He would not talk to them, no nurse, no doctor. He wouldn't even look them in the eye. And they called in psychology to give him an evaluation. Their belief was that this gentleman may have mental health issues, and that's why he's not looking at them or focusing on them. He may have a personality disorder. The psychologist ruled that out and called in an audiologist. Maybe he just can't hear. It turned out it was a lot simpler than that. A young medical student who happened to be in the ER that day was flipping through the patient's chart and looked at some social notes that I guess were taken by one of the social workers. And in reading through the notes, he discovered that the patient was a physician in his original country. And so the young medical student went up to the gentleman and referred to him by Dr. So-and-so. He said, "Hello, Dr. So-and-so. I see here that you were a doctor in your own country. I'm just curious, what kind of medicine did you practice? Were you a pediatrician?" And he engaged him based on the gentleman's profession. And the patient opened up right away. He spoke right away, and he said, "Yes, I was this kind of doctor in my country, and I actually also managed a clinic, blah, blah, blah." And he goes into quite a bit of detail about himself. And it turns out that the reason that he did not speak or look at the other clinicians is because in his country, being a doctor is a very highly respected role. And it is important in that culture to address people formally by Mr. or Mrs. And professionally, it's even more important to address them as a doctor. And he was offended by the fact that he was not addressed as either Mr. or mostly as doctor. Once that little gap was closed in terms of identifying who he was, he opened up and he was much more participatory in his own care. His outcome was actually very favorable afterwards.
Thank you so much for sharing that and those examples. Let me turn it over to Janet, one of our reactors today. So like we heard earlier, Janet is from the Amputee Coalition. And Janet, what social and cultural barriers have you encountered in your work? And how have these barriers led to misinterpretation, misunderstanding, or misdiagnosis?
Sure. Well, within the limb loss community, we have a significant number of those who have limb loss as a result of diabetes and vascular issues who live in rural areas. And so access to care is a big problem for people who live in rural areas, as well as basic communication with their providers. So they may not have good internet connection, whereas people who live in areas that have, Wi-Fi and those kinds of things, we can go to a patient portal to access our providers and ask questions and things like that. So communication can be really limited for many of our constituents. Prior to my work at the Amputee Coalition, I did quite a bit of research that involved misdiagnosis and misinterpretation, and much of it stemmed to communication problems. And I know, Seeta, you mentioned that in your amazing presentations. It was so fun to listen to, so thank you for that. But just teaching basic interpersonal skills like active listening and watching the body language of a patient and so on can go so far to reduce that type of misinterpretation, and asking patients deeper questions. We sometimes forget about, we talked about medical decision making, right, and shared decision making, and eliciting the values of the patient, asking them what's most important to you, when you're making this decision, or if you, as you're engaging with healthcare professionals, because sometimes what we assume as clinicians is in fact not at all the goal of the patient. And the previous speaker spoke about that as well, the importance of, asking them what their personal goals are as opposed to the clinical goals. And so going back to the limb loss population, for example, I remember a case of a gentleman who had upper arm amputation, and they had done all this work to find him bionic arms and hands and all these things. And, finally he spoke up and he said, all I really need is an elbow. all I want is an elbow so that I can, you know, hook it around and open doors and, you know, and so his goals were not at all the high tech goals of some of his medical team. You know, can be similar with lower limbs. You know, we have all these wonderful prosthetics, but again, back to access to care, their insurance coverage may not cover it. Their K level may not be high enough to dictate the coverage and so on. But frequently, if you engage directly with the patient and you ask them, what do you want? You know, going back to values and what's important in your life, it might sometimes be, I just want to sit on the floor and play with my grandchildren and walk down to the mailbox and get the mail and go to the grocery store. And that is an incredibly good quality of life for that person. So that was a really long response, but it's multifaceted, as you know, as you can imagine. But this presentation was just wonderful. I had the opportunity to teach first-year medical students a few years ago, and we did a lot of role play like this. So I would love to see more scripts like this, and then distribute those to the first-year medical students, right? Like right at the very beginning, as they're starting to think about interacting with the patient before they actually do, and have them play out these different roles. So, so thank you again for today.
Excellent, excellent thoughts, Janet. Kate, let's hear from you. So have you engaged with the cultural broker or navigator in your work at SCPOR?
Thanks, Anne. Great question. Seeta, that was an amazing presentation, so creative and powerful, and I think it really shed light on the example of how the complex our health and healing and administration and processes are at this state right now. So thanks so much. Have I engaged with cultural brokers or navigators in my work? I've never actually, they've never been titled cultural brokers or navigators, but I have three examples that I wanted to share with you. And in my role, I don't necessarily provide the implementation or the KT myself, but I am coaching researchers and their teams on how to best do it. So I have three examples to share today. And the first one is a computer science professor, actually, and he is working to develop an app on how to navigate different pockets of some clinical guidelines in Saskatchewan healthcare systems right now. So that's really interesting that we have a computer scientist looking into how to create different avenues of our healthcare. The second example I have is about a month ago, Saskatchewan just got their very first children's hospital. So it's a big moment in our province. We've been, I think, fundraising and building for over 15 years. So really exciting to have that. And what that means is that there's a bit of a shift in our practices in terms of giving birth in our province. So our province is huge. We have 1 million, it's not huge, but we have 1 million people, and it's the geographical distances are very long. So we have people up in Lac La Ronge, which is the very tip of the province, that have to travel about like 8 to 10 hours to give birth to come down to Saskatoon. And we have a researcher right now involving patients with lived experience and elders and knowledge keepers from Indigenous communities all over Saskatchewan. And they're learning how to incorporate Indigenous ways of giving birth in our new hospital setting. Huge multidisciplinary team, and from day one you could see that everyone is so invested and ready to make these changes as soon as the research has kind of identified them. Large focus groups with different decision makers and patients and women that have actually traveled down to Saskatoon to give birth. So we're really excited to see what happens there. And then the third example, we're working with a group of physiotherapists who are working with another Indigenous community. And what they've actually just found is that they kept asking a Cree population about their back pain. And even though they've had tons of people come to their clinic with a lot of back pain, everyone said that they don't have back pain. And everyone was really confused, like, well, why are you coming to the clinic? Like, we're helping you, we're giving you exercises with your back, what's going on? And they found out that in the Cree language, back pain, the word doesn't exist. So they use things like soreness or stiff, or they actually just say can't bend or can't tie my shoe, and they describe it as the things that they can't do. And so that was really illuminating to the whole research team, and just changing the terminology, and also how they disseminate their research findings, and how physiotherapists disseminate exercises and practices in that community. So those are the three examples that that kind of shed light for me during your presentation, Seeta. So thanks for listening.
Thank you, Kate. Those are great examples. Thank you for sharing those. Jean, in your experience, what assumptions have led to misinterpretation or misunderstanding in your work? And do you have any advice for how to confront these assumptions?
Yes, and I'm sad to say that in the employment field for individuals with disabilities, we have similar issues and concerns, and a significant amount of research that documents that culturally and linguistically diverse families, and also families that come from a non-middle or upper class financial background, often have reduced access to services that lead to employment in the community for their family member with a disability. Studies of non-white families have also found very negative experiences with service providers, limited knowledge of the services that are available. There's challenges that we often find related to stereotypes, and insufficient language translation and interpretation. And there's confusion oftentimes in the United States in some communities about the impact of citizenship status and what that might mean for their ability to access publicly funded services that support an individual to who may be a U.S. citizen or have the ability and to work in the community to be able to pursue those supports that they need to be successful. We have found that, as we look at the literature, again, our training and our case study examples really have not met that need to date. And so how do you move this forwards when it really is a need that is right now? I think, Seeta, the slide that you had about time really resonated with me, because these are people's lives and they're living them right in this moment. It's really challenging for us to say, oh, we're working on this. So I try to think about examples of what we have done to really meet the needs at the moment in time that we can. And one of the strategies that I've seen be successful is the use of community conversations. And one of the pieces that brings together, and I think, Seeta, it really hit on the fact that you can't do this without the community. You can't do this without all of the individuals that touch people in that culture and in that community. And you also can't do it without the members of the community there. And providing an opportunity and a safe space to have those difficult conversations about where there is misunderstanding and where there is misinterpretation. Because until the folks have that opportunity to connect in that way and have those conversations, it's difficult to move forwards into those next steps of saying, okay, what are our strategies that we're going to work on together to really change this outcome and have an immediate impact, because again, time really is of the essence. These are people's lives, so.
Most definitely. Thank you, Jean, for sharing your perspective on there. So I wanted to thank all of our reactors for the morning presentations, and to Seeta, thank you so much. That was a very enjoyable presentation.